Thank you very much. Lovely to be back in Cambridge. I'm a psychologist myself, and what I was asked to address in the topic really is to maybe give insight into the issues around assessing cognitive function. You've seen, thanks to Rihanna, one example of how we often do this. Can you remember some words? So is that a good way of assessing memory? It's certainly the way we tend to do it. Apologies. So in this talk, I just wanted to say that, sorry, man. Excuse me. So I want to introduce psychometric and methodological factors that are essential to be aware of when we're setting up, both in the clinic in terms of people who I assess for cognition, or setting up scientific trials as well. I do know that Dr. Renzi will also be addressing some of the aspects of this, but I suppose the first thing is the question of who's been assessed, why are you assessing them, and how are you carrying out the assessment is absolutely essential. The point being, from a psychometric perspective, we have lots of tests we can use, but a test that's ideal for one particular function, something that's very sensitive for picking up early, cognitive change of a particular type, may then be not at all useful for tracking longitudinal change, and vice versa. Another issue is that we like to think that we're measuring various aspects of cognition, memory, executive function, and semantic function, and so on and so forth. But there is really absolutely no clear consensus on what defines these domains of cognition, or how best to assess them. And I usually use a simple example of asking people, how many animals can you think of in 1 minute, as a case in point. You can go into the literature and find papers where people say, we were interested in semantic memory, we assessed it. What they did was the animal fluency test. Another paper will have a neuropsych battery. We've assessed language, and what they did is an animal fluency test. Another one will say we assessed executive functioning. It's the animal fluency test. What's going on there? Well, what's going on is that most tasks we carry out involve a whole range of interconnected cognitive functions, and it's very difficult to find any test that's a particular, simple, pure measure of one thing. Test performance can also be affected by a whole wide range of factors that have nothing to do with cognition, and we really need to be aware of this as well. Some I've highlighted there, of course, are age and education, which we can at least factor into analyses, but severity of cognitive impairment to start with, as Rihanna was pointing out, as somebody with a more advanced stage of Alzheimer's disease will probably not be able to do a whole variety of tasks, and if they can't do the tasks, we can't really reliably say that we've assessed a particular domain of function in the first place. I've also mentioned there the test environment. It's very important to be aware of the setting within which you're assessing a person in the first place, and that needs to be optimized. If a person is in a noisy or not suitable environment for testing, they may do poorly because of a distraction or whatever, and if you then crunch your numbers and assume you've assessed something, you need to optimize all of these factors. So I'm going to focus on the assessment of cognition in Alzheimer's disease, with particular reference to current models of memory functioning. First thing I want to put up, and I won't overemphasize this, but this is the point that a whole range of other factors can affect a person's performance on a task. When I say vision here, I simply mean, like myself, can you see without your reading glasses? Did the person bring the reading glasses to the assessment? If they didn't, what have you done about it? Have you just gone ahead with your testing anyway? What I have in my office is these cheap kind of non-Specsaver versions of specs. You'd be surprised how often when you take a generic set of glasses and give them to someone and say, how is that? They say, oh, that's brilliant. But the whole point is you need to optimize hearing, vision, the test setting, and so on, because, as I say, a variety of other things other than cognition itself affects tests. I want to say, with regard to this issue of what we're measuring and how we're measuring it, I'm using here memory as just a simple example. We could take language functioning, we could take executive functioning, visual, spatial, perceptual functioning, attention, concentration, and break them down the same way as well. But when quickly running through this, in terms of memory, first of all, information comes in from the environment. We actively, if we attend to it and start to process it, this is what we call primary memory or working memory.
I just want to make sure that it's just the volume is quite low.
My apologies. Yeah. Again,
no.
Not doing very well here.
There you go.
Sorry. So working memory is more than just simply asking somebody, can you say some digits backwards? Anything you consciously attend to and work on, bring to consciousness, is really what the working memory space is about. Now, what we take into and focus on and work on in working memory is not just what comes from the environment out, but also from what we've stored internally. So to my mind, working memory is a bit of a misnomer. It's probably got more to do with conscious attentional processing systems than memory, but of course there's a huge interaction between these systems all the time. In terms of memory, there's a variety of different types of memory. Procedural memory, you can't learn to ride a bike by talking about it, you have to go and do it. This is skill learning. Episodic type memory is what we typically focus on in our assessments, which is being able to recall information and talk about it from recent past, or here's another issue, from the very far back past. It's quite different for Rihanna to ask you to remember 5 words here and now, and can you remember them a little later, compared to can you remember what you did on holidays 10 years ago, or into general remote memory, can you remember details from general knowledge and the news from 10 or 20 years back. The semantic aspect of it is the factual information that doesn't have a personal connotation. Now, as a psychologist, with the differential diagnosis we carry out in our clinic, I will have to be able to assess all these different aspects of memory, or attempt to, with a whole wide range of different types of tests. But an awful lot of the work that gets carried out research-wise focuses on a very small, narrow aspect of what memory is all about, which is asking people to recall words, stories, shapes, usually explicit type, pretty recent memory function. Why is that? Well, I suppose I'll come back to that. I'm just going to say so that we need to target exactly what aspects of cognition is it that we want to assess. We also need to be able to do it within a reasonable time frame, because people can only tolerate so much testing in a particular sitting, and it also will depend crucially on the degree of cognitive impairment in the sample, which goes back to a question asked about the study that Rihanna alluded to, where in an Alzheimer's supplement study that I'll touch on, there was an improvement in vision but not cognition. I won't go in detail through the timeline, which Rihanna has already addressed also, other than to point out that the cognitive changes emerge at a particular point in time, but there's a lot going on in Alzheimer's disease at a much earlier stage. And from a treatment perspective, it depends on whether you're trying to do a symptomatic treatment, which is what we have at the moment, or something more preventive, which, if you're going to use something that could prevent change, degeneration, the time to be doing that is at a much earlier stage in the disease process. And this is where the issue of just looking at where cognition lies in relation to other ways of detecting Alzheimer's disease at an early stage. And the things to focus on here, of course, are that the earliest detectable changes are in the beta amyloid buildup, which can be going on many years before anything would be evident to me in a neuropsychological setting. You can also see that FDG PET imaging of brain metabolic functioning is occurring at an earlier stage than you're going to pick up the morphological changes on an MRI brain scan. And if you can decipher it in there, the cognitive aspects of what I can measure with sensitive tests is coming into its own in and around the time that we're getting into an early MCI stage of the disease process. So when a threshold of neuronal dysfunction is reached, this is when the cognitive and functional manifestations of AD start to accelerate. Now, building on this, the international work group, as one approach to looking at Alzheimer's disease, take an approach of trying to find a sensitive cognitive marker that suggests the person has the kind of memory change you might expect to see in Alzheimer's disease, and combines it with biomarkers. So going back to that question again of should we be using biomarkers in our research, ideally, yes, but practically, it may not be quite as feasible. This is a very important model. It's another way of looking at something that Rihanna also presented to you a little bit earlier. It's the crux of what the international work group identify as a hallmark to identify the kind of memory impairment that happens in Alzheimer's disease. To take on board any information like the words that Rihanna had thrown up on the screen there, you have to attend to it in the first place. Not only that, you have to know that you're supposed to remember it for later. If somebody simply trots out 5 words to you, you won't try to remember them. If she says you can't get out of here if you can't tell me the 5 words later, you're going to do something very different. immediately, and you won't even have insight into what you've done, but you will certainly have engaged the cholinergic system, the limbic system, the cholinergic neurotransmission, will allow you to create a memory trace you can recover for later. This then needs to be stored and maintained as a memory trace, which is where the amnestic syndrome of hippocampal type kicks in. The problem in Alzheimer's disease seems to be because of the limbic dysfunction, the memory trace can't be stably produced. Later on, you have to retrieve the information, and it could be either the case that you couldn't bring the words to mind, and I was worried, I didn't know if there's anybody she might have scared here in the audience who said, "Goo, I can't remember those words." Yeah, kind of two phenomena there. One is the person then mentions the words or gives you a cue, and they come back to mind, "Oh yes, of course," as opposed to phenomenon in Alzheimer's disease where even cueing doesn't really benefit the person much because essentially the information is rapidly forgotten. So rapid forgetting is a hallmark type problem I would use as a neuropsychological marker for Alzheimer's disease. The international work group says if you combine just simply that type of marker alone with an appropriate biomarker, you're already identifying Alzheimer's disease at an early stage. So we've decided what we want to measure. How are we going to measure it? So what about pen and paper testing as opposed to computerized testing? Well, computerization sounds like it's got a lot of advantages. It kind of has, in that it helps to standardize the actual administration of the materials and so on and so forth, and it extract a whole range of scores automatically for you. But the tests still need to be administered in the first place. Somebody still needs to sit there and make sure that the person who's doing the computerized test knows what they're supposed to be doing and are doing it correctly. And I just talk in the second part of this about some example tests. Cantab, the Cambridge automated neuropsychological automated test battery, which we've used in some studies. ADAS-COG, because the ADAS-COG is what the FDA recommends as their kind of gold standard clinical trial tool. And then the repeatable battery for the assessment of neuropsychological status, the OR-bands, I've just taken off the shelf as something I use regularly in the clinical setting and research work in Dublin. I know Dr. Renzi has used it in one of her MCI studies and so on. And it's just to compare these tasks to a degree. So in terms of the Cantab battery, all I can say is it has a very long track record in being used in academic and clinical research over many years. And they try to tailor the sets of tests to different study populations and develop norms for, for analysis. And basically, you can see that there's a specific set of tests that they would recommend for use in Alzheimer-type studies. This is designed to assess cognition during the mild to moderate stages of Alzheimer's disease. Scores of up to 14 up to 26 in an MMSE. By the time you've got a score of MMSE 14, though, a problem is that maybe the kinds of intervention you might want to look at isn't going to be appropriate to the study population. What the tests look like, I'm throwing this up to show that there's a whole suite. Cantab gets very confusing very quickly because there are a whole variety of different types of tests purporting to try and assess different cognitive domains, if you like. And you certainly need assistance in terms of being able to select out what's appropriate for your particular trial. The one that's highlighted there, the PAL, the Paired Associate Learning Task, is their kind of flagship memory assessment tool, which they now promote as something that can very quickly screen for Alzheimer's disease. Our own research in Dublin didn't find it as simply black and white discriminating as maybe Cantab have suggested, or Cambridge Cognition, in terms of sensitivity and specificity in a real life clinical setting. It's a complex task. You're asking somebody to see a design in the middle of in one of the boxes on a screen. Then, after a delay, the design comes up in the middle, and you say, which box was it in? That's easy. It's not so easy when it gets up to 2 patterns. Then, where were 3 patterns? Where were 6 patterns? And then by the time there were 8 boxes, and can you remember where 8 different patterns were? It's quite complex. This is one of the tasks that in the intervention study, the Alzheimer patients were trying to deal with. So part of the problem with a task like this is simply, can people manage to do the task in the first place, okay? So saying a little bit more about that specific study carried out by John Nolan's group in Waterford with Rhea and his assistants, looking at visual function in Alzheimer's disease and also secondary measures, the cognitive measures. I got involved with John in the CREST studies when he was carrying out intervention studies to advise with regard to cognitive measures. We in a sample of Alzheimer's patients, 31, age 80, as you can see, with mini-mentals, an average of 19, but certainly a lot of people were a lot lower than that in the MMSE. It really exciting and important is to find that there were clinically meaningful improvements in visual function and macular pigment augmentation. There wasn't any improvement in cognition over the 6 months of the study. The types of tests we used were typical fluency tests. Again, I was informed here by Elizabeth Johnson's work in terms of what we know the carotenoids seem to impact on from previous work. Animal and FAS test fluency, the Cantab paired associate learning task. We modified the Cantab recognition memory test because I wanted to have a free delayed recall word task that approximates the kind of word list tasks that we know from previous literature have been informative. There's a screening task in there, and from an executive working memory perspective, we had been advised and hoped to use a spatial working memory task, but here's an issue again. Very quickly, the researchers found that using that whole battery, and particularly that task as well, was beyond the capability of getting through the battery in a reasonable time frame, and unfortunately, it was taken out of the study early on. So, no improvements in cognition over 6 months. What does that mean? Well, for one thing, it may be absolutely too late to be using this kind of intervention for it to have an effect in the first place. Maybe it's too late for optimal cognitive assessment because people may just be at a stage where they can't really reliably carry out or validly carry out the specific tests that we were trying to assess domains with in the first place. Maybe the intervention period was too short, and if it was longer, we might have seen an effect. Maybe the tests just don't work. What I can reassure you they do, which is why I'll go on to the next study we've published. David Kelly and the Waterford group again, looking at macular pigment studies in individuals with low macular pigment density or with age-related macular degeneration, and looking at the relationships between macular pigment, the serum concentrations, and cognitive function. And what we're basically using with the same type tests again, there's also an attentional switching task included in here, which is an executive type working memory task, which was appropriate for the younger groups that were involved in this study. And just to say that there were significant correlations particularly between macular pigment optical density and a number of the different cognitive domains, again, particularly on paired associate learning. Errors more reflect the efficiency of learning, and the overall recall score would be memory performance per se. The verbal recognition memory task, which, as I say, is really in our study a free recall wordless type task, is also showing relationships. So certainly macular pigment certainly has the potential in this paper as a non-invasive clinical biomarker of cognitive health, and the MPOD was better than the serum levels of LNZ for this purpose. I'm just going to say a little bit about the Alzheimer's disease assessment scale, simply because when you go into the literature and look at clinical trials, this is what the FDA usually want to see changes on. So how does that look compared to, say, the type of computerized tests we were using in Waterford? Well, looking at the first thing about the ADAS, I've been involved in a trial with Professor Lawler in Dublin, the NILVAD trial, looking at an intervention for Alzheimer's disease. And this task, which the FDA recommends, is not easy to find a simple standardized version of it. There are several different versions around from a couple of different sources. What it contains is a word list recall type task. Again, this is quite similar to the VRM we've used in Cantab with the modification. It's looking at naming, following commands, constructional practice, being able to copy designs, and so on and so forth. Can you recall the words that you saw earlier? It's got a practice examination, looks at temporal orientation, recognition memory testing for the word list, and then aspects of cognition are rated on a particular scale. So that's the kind of content of the ADAS COG, which is, as I said, the kind of supposed gold standard type instrument that the FDA would like to see changes on. Now, Cambridge Cognition, who devised Cantab have compared findings in general studies and intervention studies where they've used the ADAS-Cog and compared it to some of the Cantab measures, and found that Cantab was more sensitive and a superior task in detecting the relevant changes. I'll also mention the repeatable battery for the assessment of neuropsychological status. Because unlike the ADAS-Cog, this is readily available by just approaching the test provider, and you can easily obtain it. It's a well-standardized type task, and again, it's just interesting to know what, again, does it cover in terms of domains of cognition. What it has, it starts with a word list learning task again, okay? So you'll notice across the 3 different approaches to testing I've pointed out, this is a key issue. It's similar to what Raina did with that 5 words which she took from the Montreal Cognitive Assessment a little bit earlier. There's a story memory task in it, a story to recall for later. Figure copy. In the first instance, the figure that you copy is to look at visuospatial perceptual functioning. A line orientation task is, again, which 2 lines are in exactly the same orientation as a set of alternatives, and this is another kind of more parietal visuospatial task. Picture naming, semantic fluency, it's fruit and veg or animal type fluency. A digit span task, this is unfortunately just forward span, which is really just attentional focus. Coding, which is psychomotor processing, it's a bit like the digit symbol coding task out of the Wechsler Intelligence Scale. And then you come back to the memory components. Can you remember the words? When I put you into recognition mode, if you couldn't bring them to mind, are you very accurate now when you're cued? Or are you one of those people who actually, even with the cueing, they're not coming back to mind? And that's what helps to discriminate on this type of battery, the people who have the forgetting that's more Alzheimer-like, the hippocampal amnesia, as opposed to people who might have memory impairment for other reasons. And there's the figure recall as well. So I'm not going to say too much about it, other than that I know that Dr. Renzi's group used this procedure to show relationships between, again, macular pigment optical density and cognitive function across a range of the domains within this test battery. So to finish up, coming back to where we started out in terms of the methodological and psychometric aspects to be aware of, it's very important in terms of deciding what are we going to do, how are we going to do it. First of all, who is being tested, because the patient population and the stage at which the patient population is at is a determinant. It's also important as to who is doing the testing, because if it's a neuropsychologist like myself who's doing the testing, there's a set of procedures are appropriate. If it's somebody with no training whatsoever in neuropsychology, it's one of the reasons I suggested in Waterford we run with the Cantab computerized type approach, where with a minimum of training, people can validly administer a complex battery. Why are you carrying it out? Is it because you want to track change over time? Is it because you're trying to make subtle distinctions between different types of patient population at an early stage? The purpose of it will have a huge determinant on what type of tests are appropriate. I forgot to mention, I just realized, sitting and looking at John, that another study that's just come out, I'm not going to present the data, John will, but I know in their 1-year CREST intervention study, a placebo-controlled double-blind study, they have found some very robust cognitive improvements related to carotenoid supplementation, but John will present that data to you sometime later. And finally, the question of what domains are you trying to assess for one thing, and do you go a computerized route or not? So the final thing I'll just throw out is it doesn't have to be an either or. There can be major benefits in taking a dual approach of selecting some of the more standard pen and paper type tasks and maybe cherry picking selective computerized tasks as well. So I'll throw it open to some questions at this stage. Thank you.
Thanks, Dr. Coen. Do we have any questions for Dr. Coen? Liz?
I'm wondering if you can comment on the telephone interview cognitive surveys that are used often in epidemiology.
They are what they are. Any task, any test you carry out is going to, you've seen the range of factors that I've put up that can affect a person's performance in the first place. If you're doing testing over the telephone, which I'm presuming you're asking, not the subjective kind of complaint, but testing over the phone, it means you can reach a larger population, but you don't have as much control over the environment within which the person is being assessed. And there isn't a single test I can think of that has 100% accuracy in terms of its sensitivity and its specificity. So the point about the sensitivity is you're trying to measure something, memory impairment or an index of Alzheimer's disease. How accurately does this test detect a person who always has the problem? And that's the sensitivity. Even bigger for epidemiological studies, a huge issue is the specificity. How often do I think there's a problem because somebody's failed a task and suggests maybe early Alzheimer's or whatever, and it turns out actually that the person has just failed the test for some other reason. So as the advantages are that you can quickly contact a wide range of people. The downside or disadvantage is the sensitivity and specificity of these types of procedures can be dubious. Think of what I've just said, accuracy in terms of identifying what you want but not misclassifying people. When you get into epidemiological studies, an awful lot of people out there won't have the problem that you're looking at. They won't have to be an early stage Alzheimer's disease. So if your test is pretty sensitive and picks up on Alzheimer's disease, it's quite likely that a large proportion of people who don't have a problem may also fail the test. So, example, something with 95% sensitivity, 95% specificity. If there's 100 people with Alzheimer's out in the community, you've missed 5 of them. But with 95% specificity, phoning up 10,000 people, it means that even a 5% misclassification rate is going to be misclassifying hundreds and hundreds of people who don't have a problem. So to my mind, there are pros and cons to it, but it's not an ideal way of carrying out research, I would have felt. Does that...
Is that relevant to ARIDS too? Yeah, I think that's why you asked the question. Is that what it is? Because basically, Rob, you may not be aware, but with the ARIDS 2 study, which is the big internationally famous study for what we do here, they also looked at cognitive function. Isn't that right, Liz? And yeah, and the data was presented at Utah at Paul's meeting last year, and they had no findings really that were of suggesting what kind of other focus studies, such as what Lisa and others have done. And I think that may be why you asked that question, because it helps us understand a bit.
Part of the problem is just how accurate these tests will be in detecting what you're looking for without kind of watering it down by including in as part of your, positive sample, if you like, people who actually don't have the appropriate type of cognitive impairment.
Do you think having somebody with greater training might enhance the ability to detect what you're trying to look for in a telephone situation? Or even in general with epidemiologic studies. So this isn't as simple as training somebody to read an eye photograph or operate a imaging device. So might there be a role for a higher level of training in the examiners?
I think, well, just like what I'm talking about here, the first thing you need to be aware of is that it's not simply a matter of, can you remember 5 words? You can't. Oh, it's Alzheimer's disease. So, anybody can be quickly trained up to administer these procedures. What exactly these tests are detecting and how they might be interpreted is part of the issue. So I think all people who are administering tests of any sort, be it on the phone, computerized, or pen and paper in an office, need appropriate training in understanding the psychometrics and methodological issues I've been trying to emphasize here, which are all a variety of other factors why somebody might fail a task. And at least the first thing is being aware of it and trained up is your first step towards the person trying to optimize, rule out as much as you can that might be noise that makes the test a little bit more accurate, if that makes sense. Okay.
We have time for one brief question.
So, how do you take into account the effective age? How do you take into account the effective age, since our interventions are typically multi-year, and is aging a disease itself? And I mean, how is this whole issue of aging taken into effect in interpreting the data, or is that an interactive effect, or how do you handle that? How do all these three different tests you've shown take into account the effective aging itself?
Again, it goes back to the simple. Really not having much luck today. Apologies. it goes back to the issue that I started with. It looked like a simplistic slide to say, but here are all the other things that might affect it: vision and hearing and education and age. It's absolutely essential that we control for these factors before we decide a test is passed or failed. Because, in other words, the usual way for any of the tests I'm looking at, the Orbans, the Cantab computerized tests, actually, interestingly, in the ADAS-Cog, it's not built into the analysis of the test scores, but in your analysis you would have to covary for age. The others are normed. It takes your age into account, and or your education is taken into account. And if the test in producing a score in the first place doesn't take it into account, you absolutely have to take it into account in your multivariate analyses. Because these, education alone, age alone, have a huge impact on any of the tests I'm putting up here, never mind a variety of other factors. Final thing to say is cognitive reserve capacity, how intelligent you are to start with, isn't necessarily well captured by education, because a lot of intelligent people didn't have opportunity. But that also can have a huge bearing on your test performance. So simply put, yes, you absolutely have to factor that in.
Is age a primary factor?
I think we'll probably have to leave that there.
I'll discuss that. You say age primary factor. It is a factor. We know that these diseases are age associated. It doesn't mean age causes the disease, but the diseases certainly become more prevalent with age. Sorry.
I just have one real quick comment, and that it's a question, I guess, and that is that, this seems to me that this area is trying to go down that sort of rabbit hole that we went with macular degeneration, and that is turning it into a drug. So like one of your slides, you said, one of your interpretations is maybe it's too late, but I would say that do you even need to add maybe? I mean, if people have gone through 70, 80 years of bad behavior and cell loss, and then we take a single component of food and give it to them for 6 months and expect it to have some meaningful effects. And that just seems like so much to expect from anything. Drugs can't even do this.
I would agree with you entirely, and you could drop the maybe, but I'd also think that when I look at the way drugs have been developed over the years, it's very rarely because somebody went looking specifically for something and found it. Quite often when somebody's investigating one thing, they find something else. So it's always, I think it was worth having a look. Now, we didn't intend to look at moderate, stage Alzheimer's patients. We hope to get in a lot of mild stage people. But when you set up the studies and go out, this is what, it's what you end up with. Too late, but the intention was really to try and get in at an earlier stage. The recruitment becomes an issue when you get into the real world after you've set up your trial.
Thanks very much.
Thank you.